You.
Well, you did a great job, Karen, and I certainly appreciate that. Um, it's a real interest that I came to Tennessee and moved to Tennessee in mid 1993. And as all of you may remember, January 1, 1994, TennCare started. And at that point, there were 7 MCOs. It was a disaster. And it got me very involved in organized medicine. Um, Here, let me. Here you go. That's me. And one very really interesting thing I think was the fact that I spent a year as the president of Tennessee Medical Association in 2022 through 2023. As I traveled around the state and around the southeast, I found that physicians were really beat down. They were really experiencing burnout, wanting to leave medicine, unhappy for a variety of reasons, and that sort of led me down in that direction. We did establish a physician wellness committee at the Tennessee Medical Association, and I've been able to speak at several occasions on this issue, which I think is very important. Can everyone see the screen okay? The slides okay? I guess so. Disclosures, I have no disclosures, no commercial support. I have no financial disclosures of any sort. What are learning objectives? Number one, let's discuss physician wellness and how to stay healthy. Two, we're going to talk about career fatigue, stress, burnout, and how to identify and deal with these. And then as we go further into it, we're going to look at what to do if you find either your spouse or one of your colleagues may be suffering from stress or burnout, how to identify it and what you can do about it. We're going to talk some about the prevalence of physician suicide. And then we're going to talk some about some specific groups, employed physicians, which when I came in 1993 were almost non-existent, but right now are a large percentage of physicians are employed. Makes totally different concerns. And then, of course, the senior physicians, of which I now have become one. Very interesting quote. This quote goes all the way back, if you see, to 2001. And I think it's still applicable today. Classical training teaches you how to practice medicine, but it doesn't teach you how to live life as a physician. They're doing a little better of that now. Back when I was in medical school 50 years ago, it's like, suck it up, 100-hour work weeks, what's the big deal? I did it, you can do it. It's a little better, but still, I don't think they do a very good job of teaching us how to live life as a physician. So what does Mayo Clinic say? What do we do about healthy living? And this is true across the board. This is true for everybody, not just physicians. Balanced diet. Okay, busy day at the clinic or really busy. We have time to wolf down one thing. We send one of our nurse or front desk people to Hardee's to get us a burger because we just don't have time for anything. That isn't really what they're recommending as a balanced diet. Regular exercise. When I get home from work at 8 or 8:30, it's like, forget it. I'm not going to do it tonight. Do we really have to take the time we need to get moderate to vigorous activity? 2 hours on a Saturday probably doesn't make up for the fact that we haven't done anything all week long. Healthy body weight. Don't do very good at that one either. Moderate alcohol intake. This is what they said recommended before Robert Kennedy got in. Robert Kennedy now says, however much you drink, drink less. But I think this is a very reasonable thing. No more than 2 drinks a day per man, 1 drink for women. And, interestingly enough, 1 drink is like 1 glass of wine. So if a man and wife share a bottle of wine, there's 5 glasses of wine in the bottle. Share a bottle of wine, they've exceeded what's recommended for them, especially if they do that on a daily basis. And we did have a talk back in May about alcohol issues because sadly enough, Alcohol is one of the main problems of some physicians and the ones that have to come into treatment. No smoking. We're doing great about that. I've seen some pictures of physicians back in the 60s where there'd be ashtrays sitting in the exam rooms. Well, obviously, I think we've caught on to the smoking issue. And then regular sleep. Again, I don't think I do very good about that. I've gone by in 5 to 6 hours of sleep since I was a college student, and I'm a little better now, but still, how many of us get 7 to 8 hours of uninterrupted sleep? I bet not very many of us. So anyway, this is what Mayo Clinic says all people should be, and I don't think we're exempt from that. Well, let's go on to see what's been listed as what are stress busters and look at some of the same things we just talked about: physical activity, quality sleep, balanced nutrition. Now, they had a few more things, mindfulness, and we don't have to have time to go into this, but if you do practice mindfulness, you can do that in 5 minutes in between patients to just sort of calm yourself down, especially after we've had a particularly difficult interaction with a patient. Supportive relationships. The nurses we work with, our spouses are the main ones. Access to nature. Go out and take a walk. And Tennessee, we're very blessed. We have the Smoky Mountains and a lot of other parks and stuff to go to. Mental health care. We'll talk about that some, but again, it's not something that we do a really good job of ourselves. Interesting enough, LifePoint, and I'll bring up LifePoint again after a while, but LifePoint says here, have a career, have a life. We need to be able to do both. But look at this, and this was from a while ago as well, but I'm sure it's still true. Let's look at the work-life balance. We have the work and we have family. But look at the numbers. If work interferes with family, it increases depression and anxiety about 2 times. Look at the other side. If family interferes with work, oh my, if our family's getting in the way of our job, look at the numbers. Hugely increased. So it sort of seems, obviously work becomes a priority. And I found this balance really very interesting at how tremendously increased depression, anxiety, and substance abuse was when we found that our families were getting in the way of our work. So I'm going to go through a couple of things. Medscape puts out reports every year. This is from 2024, but they interview physicians and they ask them a lot of questions. And I'm going to go through some of the questions that they had asked. First off, what are physicians doing to maintain their happiness and mental health? Look at number 1, spending time with my family and friends, getting away from work, putting it aside, going on a cruise, leaving your work behind, especially now in the days of EMR. We can carry our work with us anywhere we go. But getting away from work is really important. Doing activities or hobbies that I enjoy, like the garden, like to read. What do you like to do? Those two, and then of course exercising is there too, and then getting enough sleep. Those are the big ones. But spending time with family is far and away felt to be the most important thing to help us to keep happy. Okay, then here's the flip question. What contributes to burnout? Look at number 1, too many bureaucratic tasks, charting, paperwork, prior authorizations, getting approval, especially the family physician. Just about every time I send anybody for anything, I have to get approval from the insurance company to do it. And they say that right now, and I don't personally have that problem as much, but they're saying that the average family physician is doing 40 prior authorizations a week. Well, there's no way in the world I do that. I sort of send it off and try my hardest to find something that is covered. They don't have to get a prior authorization, but we can't always do that. And there's times when we need to get approval to put someone in the hospital. We need to get approval to send someone for an MRI. We need to get approval to send someone to do anything. Too many bureaucratic tasks, and it's gotten far worse since the electronic medical record came about. Lack of respect becomes interesting when suddenly, in terms of me having my private office and having an office manager, I now have a CEO that I work for, and he's sitting there saying he has to pay the bills. So what do we get? I've seen this just in the 15, 16 years I've been with Mountain Peoples. 16 to 18 patients a day to 21 patients a day to 25 patients a day. And now they're talking about 30. Taking away support staff. I used to have 2 nurses, one to bring the patients in and do that sort of thing, and then another one to work with stuff like referrals and prior authorizations and stuff. Took one of those away. Now I only have one. So those are the 2 big ones. Too many hours at work. I think we all would say that. And that's sort of, if we're spending 12 hours a day at work, we just don't have time to spend time with our families. Insufficient salary, and of course that's interesting because anytime we talk about increase of salary, the administrator talks about increase in work, increase hours, whatever. The electronic health record, big. Lack of respect. It's another big issue that we're all facing where patient comes in and we say, oh, you need to be starting on metformin for your elevated hemoglobin A1C. Well, I read online that metformin is a very dangerous drug that I shouldn't take. We spend a lot of time having to correct misinformation that is brought forth to us that the patient brings to us from what they read online. And then here's the last thing. Why have you not sought any mental health? This is one we're all guilty of. I can deal with it myself. I don't need any help. The risk of disclosure to the medical board is better. We have, but with our physician wellness committee at the TMA, we've worked with the board of medical examiners and taken a lot of the stigmatizing questions about mental health off of the medical board. But a lot of the hospitals still have the same thing. Have you ever been treated for depression? Do you take any medicine for depression? And that's a negative thing in their minds. We don't want my colleagues to find out. But, still the big ones are, I don't need anybody's help. I can take care of it myself. Well, as I said, there's been stigma. Federation of State Medical Boards said mental illness should not be distinguished from physical illness. The focus of licensure should be impairment. Is it impairing your ability? Hiding stuff through alcohol, through whatever, is impairing. Getting help should not be. Joint Commission said, let's remove any barriers that inhibit clinicians and healthcare staff from accessing mental health services. We haven't gotten, that was 6 years ago. We're still trying to make that happen, especially in a lot of the hospitals. And then, of course, the U.S. Surgeon General. Now, that was the previous Surgeon General. That was not Robert Kennedy Jr. This was, but we must ensure that every health worker has access to affordable, confidential, and convenient mental health care. And we should eliminate any punitive policies. So there have been several different high-level groups that have said, you know what, we really need to cut the stigma. It's still there, sadly enough, in many instances. hospitals credentialing, insurance companies credentialing are still, sadly enough, asking some of those questions. Dr. Lorna Breen, and I'm sure you've all heard of her. She was a internal medicine physician, worked in the emergency department. Back in 2020, she got COVID, and she had it pretty badly. She took some time off. She tried to come back a little bit too soon, and was just exhausted, worn out. So she took a leave of absence. And her leave of absence, she got really depressed. Oh my, what are they going to think of me? What am I going to do? She sought help. She was even hospitalized for a period of time in a mental health facility. And that made it even worse, to the point that she said, well, I'll just never be able to practice medicine again. So she committed suicide. She was only, I think, in her early 40s. Corey Feist is her brother-in-law and founded the Lorna Breen Heroes Foundation, which basically cuts down removing barriers in licensure and credentialing. There's something like 4,100 hospital systems around the United States that comply with the Lorna Breen Heroes Foundation. Sadly enough, there's only 2 hospital systems in Tennessee that are compliant right now. And they're not the big ones. They're not the ones you think about. They're 2 Hospital Corporation of America hospital groups. At any rate, we do have are compliant at the licensing board level, but we are not at the hospital levels in almost all of our hospitals, including Vanderbilt, UT, and some of the large major ones. Okay, so let's think about it. What are some of the symptoms of what's causing us stress? What are we doing? And the one we see a lot is that we get short-tempered. We snap at people. Although it's number 8, I probably would put it up higher up. Skipping work, leaving work, avoiding activities. I used to love to go out and go for walks. I never go for walks anymore. And then we get behind in charts. That one of the doctors in my group, I had to get on him about it. He'd get 300 charts behind. Well, there's no way in the world you can remember what you did 2 weeks ago. So, and then of course, as I mentioned, from the Physician Medical Foundation, alcohol is one of the things that physicians use because it's not monitored, it's not watched, and whatever. So, abuse of alcohol becomes an issue. Isolating yourself, withdrawing from responsibilities, negative attitudes, but usually you start seeing it in people taking out frustrations, anger, snapping at the nurse that works with us. I mean, she's just trying to help me, but if I'm snapping at her about things, it's not a good. We've noticed we may be having a little bit of stress is starting to affect us. I really like this. This was about 10 years ago, but this graph I really like, because if you look at it, level of pressure and performance, low level, low pressure, low performance, we're bored. But then as the pressure builds up and the performance builds up, we go from a comfort level, which would be really nice, to stretching us a bit, to it becoming a strain. And when it gets to the strain level, increased pressure, you need to see more patients, you suddenly start making bad decisions. Fatigue, exhaustion, you have health problems, breakdown, and you reach the point of total dysfunction. You reach the point that I can't function at all anymore. So if you see, you really want to be on the upper part of this graph, not when it starts going down. And then, of course, all the way at the end, you've got burnout and physicians leaving medicine. Well, what can we do to address burnout? This is from the Physicians Foundation, which is a group here in Tennessee. A survey done, 1,500 physician responses. Over 60% of the physicians had feelings of burnout, anger, tearfulness, anxiety. 80% believe that there's stigma, so they don't want to seek mental health care. And only 30% believe that their workplace prioritizes physician well-being. The workplace prioritizes money to pay the bills, and they don't really see how that affects the physicians. And then more than 30% don't believe that resources for suicide prevention exist. Well, yeah, they do, but they don't know where to look for it. Well, and then here's about the same period, the AMA response to burnout. The AMA is developing a recovery plan. It's still got a ways to go, but it wants to, reducing physician burnout is very high on their list, because if physicians and in our group, if we all leave medicine, there aren't enough people coming up behind us to replace us. So we really are in a bad position, especially as people are leaving early. Give one example of an internal medicine physician. I talked to him recently, and he retired at 50. He and his wife, who was also a physician, they retired at 50. They never had children, so we got all the money we need. And I hadn't seen him for several years. And I saw him again recently, a couple months ago, and asked him about that. You know, no, that wasn't the reason that we left. The reason that we left is I had a patient that needed a specific medication, and I went through all the steps. I went through the prior authorization. I went through the peer-to-peer. I went through everything, and finally had someone who did not even know what I was talking about, who denied me again. And he said, I was so angry, I threw my phone across the room and decided I didn't need this. And this is really interesting, because I talked to his brother, and his brother said this physician went into the emergency room quite frequently with horrible headaches. The second he left medicine, the headaches stopped. So obviously, he was burned out, and I'm sure there may be some people that we're speaking to that may be burned out as well. This was a survey of 13,000 physicians from 30 states, and look where family medicine is, one of the highest burnout by specialty. The specialists don't seem to have it nearly as much as the primary care people do, 58%. And it reports that up to 26% of current physicians will leave medicine in the next 2 years. I don't think that's quite played out. We've had some successes, but there are a lot of physicians leaving early, including a recent article in the Journal of the American Medical Association that said the average female physician leaves practice at age 48. We don't need to be in that position. Another graph that I really, really like, it looks at what are the effects of burnout, personal, professional. Professional, we've talked about. Patients aren't as happy with us, decreased productivity, leaving medicine. Those are on the, but what are the personal side? Let's look at what it does to us. Broken relationships. Many physicians are not with their first partner. They've had a divorce, I myself included. Alcohol and substance use disorder. Less substance use these days. Alcohol, you can go out, you can buy it. It's not measured. Most of the urine drug screens don't even measure for alcohol. So, alcohol is one that's pretty easy to abuse and not show up until it becomes a real problem. Depression and suicide. And we're going to talk about suicide in a minute, but physician suicide is another major issue. It says approximately 400 physicians are reported to die by suicide each year. That's across the United States. On the other hand, I think this is a very, very low number, because one of the interesting things about life insurance is if you commit suicide, your life insurance is declared null and void. Well, a lot of physicians, especially in the early part of their practice, if you come out of medical school only $300,000 and you have $1 million life insurance to pay all this, and you commit suicide, suddenly your spouse is left with a $200,000 liability. So I don't think it's reported nearly as much as it's happening. If you look at the rate of suicide among physicians, it's twice the national average, higher than any other group. And this is look at the third bullet point, a very important thing. Women physicians are more likely to commit suicide than their male counterparts. Look at the numbers, 1.87, and that's for all physicians, but women are at 2.78, almost twice what male physicians are. And then, of course, I think you all know this. There is if you're really, really burned out, there is a hotline, lifeline, a 988 you can call. You will get in touch with someone, generally a social worker. They'll try to get you hooked into something. I still think it could be better, and we're working on trying to develop something in Tennessee for Tennessee physicians. But that's still in the pipeline. So now if we're talking about it, where do we go? Let's work on setting up a personal crisis management plan. And you want to think about this before you're in crisis. Reach out to support is important. And then here is NPSA. It stands for National Physician Suicide Awareness. And that day is September 17 every year. But that group does do a lot of very good things to try to help prevent suicide. This is, and I hope you can get the copy of these slides and can download this. These are 5 questions. What you need to do is think about this when you're feeling fine. Sometimes you got a little time for yourself. Write in the answers. Write down some answers. Put it where your spouse or significant other can find it if you need it. What are my personal crisis warning signs? Images, moods. I get angry. I lash out. I don't want to eat, or I eat too much, or whatever. What are the personal crisis warning signs? What do I do to cope? Go for a walk. Take a day off. Get out of town. Take the kids out to the zoo. Do something like that. Mindfulness. We talked about that a couple times. And again, there's no time to really go into how to do it. But you can do mindfulness in 5 minutes as a way to practice to sort of calm yourself down, especially after a very difficult patient that you see in the office. Who are a few people that you could turn to for relief? It could be another provider, it could be your personal physician, whatever. Who are some people in social settings where you might turn? I love going out to Texas Roadhouse, whatever. So there's places there too. Who can you ask for help? And then, of course, who do we contact in crisis? Primary care physician. Do you have a psychiatrist? Is there an employee assistance program? There often isn't. But what can you do? Who can you contact? This is a great thing to copy down. And I think you can get a copy from the National Prevention Suicide Awareness website as well. Write in the different, some answers and put it where your significant other can find it. This is another something, I don't know if you all are aware of this, but this is available, TennesseeProviderWellness.org. It's promoted by the physician, impaired physician type programs and whatever. It's Tennessee. It's an online tool. You don't have to put your name in. You can click connect, and you can say, I don't want this shared, or I really would like it shared. But there's a series of questions. It takes about 20 minutes. It's really interesting. It's an anonymous mental health screening. And at the end of the day, you can realize, am I just kind of denying that I have a problem, or am I doing okay? It's really important, I think, to see that this screening questionnaire is available. Just takes a few minutes to do. If you want to connect with someone, you can, and they can get you tied into someone in your area if you really feel that you're going to need some counseling or some extra help. Okay, we're going to change subjects for a little bit. Up until now, we've been talking just about ourselves and what it can be to us. Well, let's talk about, what if it's your partner? All of a sudden you realize, he used to be happy-go-lucky, he used to be really positive, and he doesn't, we don't talk. He doesn't seem to be as happy as he used to be. He just is having some problems. Well, one, I mentioned this before, the Tennessee Medical Foundation, that's the group for impaired physicians, whatever. 260 physicians a year get referred into them. Burnout, depression, substance use, anger. And interestingly enough, 20 years ago, it was mainly anger or impulsive behavior. And now it's almost all substance use. And of that, it's almost all alcohol, like 80%. Alcohol is the drug of abuse for physicians right now. And when you're drinking a lot, it's not a good situation. They do a phenomenally good job, and it's not reported. It does not go on your record. They're really good people. So you realize that one of your partners, one of your friends, is having some issues. What can you do? First, how can we prepare for the conversation? I mentioned Tennessee Medical Foundation. Are there local groups? Are there local psychiatrists? There's some psychiatrists in the area that I know, certainly in the Nashville area, that will see physicians and will do it in such a way that it doesn't impact their standings. We talked about the signs and symptoms of burnout. That's true both in terms of us and in terms of our partners. Are there some educational programs? Yeah, if you want to go online, you can find all sorts of programs, free CME things about burnout, mental health, mindfulness. Number two, okay, find the right time. End of the day, we just each saw 25 patients. We're really tired. Is it a good time? No. Middle of the day, we know that, maybe our lunchtime, but, we get interrupted by the nurse. This patient called up. There are other medicines. Can you send them in a month's supply, whatever? We're always, all through the day, we're distracted. So I need to kind of think through, is there a time when, one, there won't be any interruptions, and two, we're not exhausted from just having seen 25 or 30 patients? What's the right language? Man, you're really burned out, aren't you? No, that's not the way to say. You just don't seem quite yourself. Is everything okay? I think those are valid questions without trying to stigmatize or put someone on the defensive. And then listen to what they say. How long has this been going on? Something happened? Yeah, my favorite patient just passed away. Whatever, What can I do to help support you? Have you thought about getting some help? I think those are some questions we can ask in our conversation. It wouldn't have to be necessarily one conversation. Sometimes this takes place a little bit at a time. I'm fine. Just leave me alone. Well, you don't want to talk about it, but think about it. Whenever you're ready, I'm here. I want to help. And then the crisis management plan, we all should develop one, have it written, identify with some of our contact resources. Remember, we saw it in there that who do I call? Who do you call? When you're in the middle of a crisis, you don't necessarily have time to go looking for asking the person, man, you got a problem. Who can I get in touch with? And then if you need further help, locate a specialist or facility. Um, a lot of area and regions and whatever have access to something to enable you to get help, especially confidentially. And then support your partner. Hey, I'm here for you. Employed physicians, big group. Look at this. This is from the American Academy of Family Physicians. And the orange line are the active AAFP members. The blue line are the new graduates, new family physician members. Look at that. By 2021, and that's still 5 years ago, I'm sure it's higher now, 93% of all new graduates were coming out and employed. They owed so much money, they really didn't have time to develop a practice or take out another loan. When I graduated from medical school in 1979, for medical school and college both, and I went to a private medical school and a private college, my total indebtedness was $35,000. And now the average people are going in over 300,000. That's a lot of money, and I can see why they're going employed. They don't have another $100,000 to set up a practice. But interesting, if you look at not all AAFP members are new graduates, but even among all the rest in this survey that they took, 70% of physicians are employed. And I must admit, I have worked since I came back from the mission field in 1993. I've worked as medical director for 3 different community health centers, but always as an employed physician. So, the number of people in private practice, especially in family practice, is going down very rapidly. So back to that survey that we talked about a little bit ago. What workplace measures would help most with your burnout? Pay me more. Have more support staff. I think those are, and then make work schedules more flexible. Well, that's really hard to do because, of course, secretaries, nurses, whatever, you have a cadre of people that work with you. So to say, well, yeah, you can come in at 10 o'clock instead of 8 o'clock, it's just probably not going to work. Increase physician control. In an employed physician situation, that doesn't happen. 41% said they want more control. More respect for administrators. We talked about that too. It's not they don't respect you, but they sit there and say, hey, I got to pay the bills. My cost of utilities, the cost of medicines, the cost of staff is going up, and the money we're getting back from the insurance companies isn't. So the only way to fix this is you have to see more patients. And look at that. Look the next one down. Lighten patient loads. Pay me more to see fewer patients. That's never going to happen. So what have we done? One, reduced work hours. Well, I found in my personal situation, I loved delivering babies, but I hit my mid-50s and said I couldn't stay up all night and then be able to get up and go to work in the morning. So I changed jobs to where I was doing only outpatient. What can we do? Get more staff to increase to ease the workload? That's not going to happen. Actually, staff seems to be getting cut. Productivity becomes an issue, and productivity pressure goes up and up as the number of patients we're expected to see climbs as our reimbursement per patient goes down. And then, we just sort of left medicine altogether. That's how we can change our work environment. Here's an interesting toolkit. We mentioned them before, Life Bridge, when they talked about relationships and family life, and work life balance. This is a toolkit that looks at best practices from across the United States and has some models and funding requirements of things that can be done to try to ease some of the pressures and burdens on physician practices. Establishing a chief wellness officer. Now, a lot of the hospitals have done this, but the chief wellness officer needs to be there to promote the physicians to administration, not the other way around. And sadly enough, what's happening is often they're there promoting administration and trying to convince the providers to just put up with the problems. We need a chief wellness officer that's going to be there, that's going to be promoting the needs of the physicians. Hospitals have developed, and this is back from that Life Bridge thing, a hospital wellness plan. And look at that blue thing in the upper right corner, clinician well-being. We have better outcomes, we have better productivity, and if the physician is happy and doing well. And when a physician leaves, they estimate that it costs over $1 million to replace a physician. So hospitals don't want to do that. And then let's talk about retirement for a minute. You don't think about that until you get there. But like I said, I'm a PG 47, and I graduated at age 25 from medical school. So that means I'm 72 years old. So that means it's time for me to start thinking about it. What do we want to do? What would we like to do to retire? One, travel more, do more leisure activities, dine out some. Those are some of the big things. Interestingly enough, my financial advisor said there's 3 stages of retirement. There's the go-go stage. When people first retire, they go on trips, they go on cruises, whatever. There's the slow go stage when they just sort of are tired and don't want to do a lot, or maybe start having health issues. And then there's the no-go stage. Go, slow go, no go. They said that those are the 3 stages of retirement. And you don't have to fully retire. You can go to part-time, which is what I've done. I keep going back to that one where we asked all these 13,000 doctors, why do you want to keep working? I'm still working part-time at 72. I think I have more to contribute. Now, I have cut back. I'm no longer doing full primary care. I'm only working 1 day a week. At 1 day a week, you don't have time to do a lot of primary care stuff. And most of my patients I've had to turn over. But I found in my area, there was a huge problem of addiction. And so one of the things I've been doing is working more on working with patients with substance use disorder and addiction. I have more to contribute. It's my passion, it's my identity. And a lot of people don't have enough money saved up. We should be putting money aside even when we're early in practice. Again, the same financial advisor that I had said he had been counseling several people that were getting ready to retire that were specialists that were making twice what I make, and they spent every bit of it. They had a big house, they had new cars every year, they went on trips all the time, and suddenly they went to retire and found that they didn't have anything put aside. On the other hand, why do people retire? Why do doctors retire? Burnout. Biggest, 74%. That's why they want to retire. And as I said, female physician, the average female, and of course some stop practicing when they have their children or whatever, average female physician leaves medicine at age 48. I saved up enough money. I planned it well. I didn't overly spend. I want to pursue my personal passions, golf, whatever you like to do. I want some more time with my family. As we get older towards retirement age, guess what? We have grandchildren, and very rarely do our grandchildren live right next to us. I had 3 children. 2 of my children live in the greater Knoxville area, but they're still over an hour away, one way. And my 3rd lives in Atlanta. But I talked to one of my patients. One of my patients said he has 3 children. He lives in Scott County, which is where I practice. He says he has 3 children. One lives in Chicago, one lives in Dallas, and one lives in Los Angeles. Well, how do you spend time with them? You need to take time away to go visit. And then, of course, health concerns. We don't think about that. Usually that hits us unawares. But as we get older, things start to happen. One of my very best friends from residency just recently passed away from metastatic colon cancer. Makes you stop to think as we get older that we start having health concerns. The delegate from the American Medical Association senior physicians just recently passed away from pancreatic cancer. And she was on top of it. She always was having tests done. They found it early. They operated early. They told her she was healed. And as with everyone else with pancreatic cancer, within a little more than a year, she was dead. So, health concerns become a problem as we get older as well. But on the other hand, what are the things we do not want to do? If these are both the same physician, one is the elderly physician still practicing. You can see he's got the calendar, he's got the time he's seeing patients and whatever. And then the other, he's not seeing patients, he's not keeping up with anything, he has no interest because medicine was his only interest. Sitting on a park bench, well, that is a sure answer to not surviving very long. They go gradually, very rapidly downhill when they have no interest. So, as you get ready to retire, think of interest, volunteer, teach. Some of the things we tried to push as the wellness committee for the American Medical Association for the senior physicians, get involved. Go on work crews, go to Africa, go to Central America, whatever, on a mission trip. Teach, even at the high school level, to have a physician come in and talk about diabetes to a high school health class, great deal. Don't just sit there and do nothing. Keep involved. Well, as we're coming up on our hour, I'd like to kind of leave you with this. Happiness is a choice. Happiness is a habit. And happiness is something that you have to work hard at. It doesn't just happen. But I think all of us want to be happy. All of us want our families to be happy. So I hope some of the issues that I've raised are issues that are helpful. And we do have a few minutes. And I hope I didn't put you all to sleep. But I think if I stop sharing my screen now, I can get to some of the questions. Are there some questions there?
I do not see any questions in the chat box. Does anyone have any questions for Dr. Capparelli or comments?
Yeah. Hi, this is Dr. Riley. And Dr. Capparelli, thank you for taking on this challenging and important topic. I've wondered a lot, been thinking a lot about where AI is going to fit into the physician burnout spectrum. And I'm curious as to your thoughts or others' thoughts about this. I think there's parts of it that are going to relieve some administrative burden and documentation burden, which weighs heavily, we know, on providers. Certainly, access to information. You think about open evidence and our ability to really tap into things very quickly, information really quickly. But I also think there's going to be some challenges with it. And so I was just curious. Um, Thoughts about where AI may fit into this.
You raise a really interesting point, and it's something I didn't really get into. But when I was a child, my family physician uh, saw patients in his home. His living room was his office, and he kept all of his medical records on 4x6 cards. 4x6 card had my name and my date of birth at the top, and then there'd be a date, and here would be his office note: sore throat, strep, penicillin. 4 words. But he took care of us. The medical record at that point in time was supposed to be something that enabled me to know what I did. And now, of course, the medical record, especially in the age of the AI and has become huge, page after page. And unfortunately, sometimes we check off boxes that we didn't really do. For example, a 65-year-old physician that I was medical director over at one point had checked off physical exam all normal. Well, he was 65. He was seeing a 35-year-old woman, and part of the all normal on the exam was an unclothed breast exam, pelvic exam, and rectal exam. Well, he didn't do that, but the note said he did. So, we get into some of these AI issues, and insurance companies are using it tremendously too, where in the old days, when they'd come to look at our charts, we'd bring in these big, huge stack of paper charts, and they try to go through them. Now they can sit there and automatically go through and decide that we didn't do 15-point review of systems or whatever as far as reimbursement for a 214 visit. Sometimes AI can be more of a problem, and I guess perhaps as I'm older, I'm less of a fan, and other people may have a better impression than I do. There are parts it's going to help, but I think there's parts it really takes away from my individual one-on-one relationship with my patients. What do you think?
We do have a couple of comments. One is, I think patients having direct access to message their doctors in the same way they would text a friend is leading to increased burnout for sure for both physicians and staff. And another comment is AI will become another liability issue, stress, and adds to note bloat, harder to find information in the chart. So, and from an auditing standpoint, AI could be used as a tool, but not as the definitive record, because the physician or the provider is the one that's responsible for what's in that note. So, just a kind of a note of caution there.
It's going to take a while for us, I think, to really adjust to it and to use it appropriately. I had one particular specialist that I saw the patient, and the patient said that this specialist never looked at me. He poked his head in the door and said, "Doing okay, I'll see you in 3 months." And that was it. He didn't even walk in the door. But interestingly enough, I got an 8-page report of all the stuff he said he did, including a full neurological examination. Interestingly enough, the patient was a diabetic, only had one leg. You can't very well tandem walk on one leg. And so, we often, I think, get lulled into this sense of, if we check the boxes, it looks good, because we're writing our note not as my doctor did when I was a child, so I know what I did. We're writing a note to make sure we get maximum reimbursement from the insurance company, and that's a really sad place to be.
It's become more like a receipt. as if you would go to Target and purchase something and need to make a return. You have to have that receipt to get your full refund. And so that's kind of the way I look at it. And unfortunately, the whole checkbox thing, I've read some notes that I know good and well didn't happen. And all that does is make you question the validity of the rest of the note. So it is a very interesting time that we're in, and we certainly need to make sure that whether you use AI as a tool or not, that you still are ultimately responsible for that. So especially in the day of down coding. We've just got to make sure that the documentation supports, not that we need more documentation, we just need documentation that supports what goes on behind the door.
And if some of the note is automatically done by AI, we need to make sure we read the note, because that's another shortfall that we can often have happen, and that is that we sadly enough just assume that everything that was put in is appropriate, and so we just sign it off and don't really go back and read what's there. And we really need to make sure that we follow up and read what's there, which takes more time.
Yeah.
Any more questions? We've got 1 minute.
I don't see any more in the chat there. So if nothing else, Dr. Capparelli, I just want to thank you again for just such a timely and important topic here. And any further questions can be emailed to me directly, and I'm happy to forward them on to Dr. Capparelli and for a response there. Please remember to complete the survey that's going to be emailed to you shortly. And I hope that you'll join us next month for Advancing Early Detection of Lung Cancer, a multi-pronged educational initiative to elevate evidence-based screening practices. So that should be a good webinar as well. So let me know if you need anything. Again, thank you so much for being here. Dr. Capparelli, thank you for your time and sharing your expertise with everyone. And I hope you all have a great rest of your evening. And take care.
Thank you all. Good night.
Good night.